I'm a radiation oncologist, and my talk will be how to radiate a patient without giving a scar. I'm not burning any patient here. So this topic will be a little bit offbeat to the theme of the conference today, but we thought like this will be relevant in your daily clinical practice for your patients and friends and family who are undergoing radiotherapy for your patients. So as Dr. Chinnababu has already mentioned, we do not treat any patients with pregnancy with radiation. So how do we manage then? Suppose you have a locally advanced cervical cancer and who's been diagnosed. This is a common, not so common, but we do come across such situations. So if you have any locally advanced cervical cancer which is diagnosed during the pregnancy, what we do is we treat them with some safe chemotherapy drugs. First trimester, we do not give any kind of chemotherapies. First trimester, if the patient is diagnosed, we have to terminate the pregnancy and then go ahead with the treatments. In the second trimester, suppose you are diagnosing a patient in the second trimester, then we give them some safe chemotherapy drugs, and these drugs they do not cross through the placenta and because of the barrier, and even if it crosses also, it is not harmful for the baby, and usually it will be paclitaxel based chemotherapies, and we have treated some patients like that and they are doing very well. After the chemotherapies are done, we take up these patients for radiotherapy after the delivery of the baby, and delivery is always the upper it's not the LSCS, it should be the I'm not sure what incision you call, classic section. Yeah, thank you. So that's about for the topic. And this is about MR-LINAC technology. As I've already mentioned, for the past 25 years, I've been treating patients with radiotherapy. But the kind of advances what we have now compared to what it was earlier is unparalleled and unmatched. I'll not go into the details of all those things, but this is the latest machine what we have in our hospital. This has been first time introduced in India in our hospital, and it's been successfully running for the past 2 years. And we have treated almost all 500 patients, of which almost all 100 patients belong to gynec cancers. So just to explain how this MR-LINAC treatment is going to be different from any conventional radiotherapy machine. So whenever we take up a patient for radiotherapy, what we do is, apart from drawing the target, whichever is, suppose you are treating a cervical cancer, apart from drawing the cervix, uterus and all, we have to give some safety margins into the surrounding normal structures, because there will be always chances of this bladder or rectum which will be the filling variations, which will lead to lot of movement of the uterus and cervix, which might lead to these filling variations will push the tumor out of the area, and that might lead to lot of missing of the tumor, or if you give more margins, you'll be treating lot of normal tissues. So if you give 1 or 2 millimeters margin, there won't be much difference. But as you go increase the margin, so what happens when you increase the margin, you're taking lot of cervix, lot of bladder and rectum into the picture, and which will lead to normal tissue side effects. This is a machine which is integrated with MRI. You do not know, patient need not go outside. It is in the same room where we take up the patient, and it's a non-ionizing radiation, very safe for the patient even if you do n number of scans. And in this case, you can see the soft tissue resolution. These are our own patient, cervical cancer patient, which was treated, and we can see both the lips of the cervix has been invaded, and the left-sided parametrium is completely occupied with the tumor. And then this machine also has a real-time imaging. That is, so this is where even during the treatment, when the patient is undergoing the treatment, still we can see how the beam is getting delivered. Suppose if there is any gas which is passing through the rectum at that particular time, the beam will switch off automatically. Earlier we used to do it manually, but now it is going to be switched off, and this is how we can treat these patients. So this is the basic workflow. Once the patient is taken up for radiotherapy, the patient will be lying down still on the machine, and we take up a 2 minutes or 3 minutes MRI scan. This is a short sequence scan. Usually for gynec cancers, we take only the T2 sequence of the MRIs. And once the MRI is done, we do all the normal tissue and all other target tissue contouring and all. Once everything is done, we give a small margin, around 3 to 5 millimeters margin into the normal structures, and then go ahead with the planning and treat the patient. So these kind of challenges which were there with cervical cancer treatments, especially, which was motion of the uterus or the cervix, and then the GTV will also, I mean the gross tumor volume will also respond during the, because we see these patients in a very locally advanced and bulky tumors, they keep on reducing during the treatment, and all these challenges are overcome by this machine.